Thank you. Thank you very much, Ariel, for your kind invitation. I'm privileged to be part of this course, and I congratulate you for putting together this program, which is really very, although dense, very intensive, and I guess interesting for the whole audience. I guess, Ariel, that I have 20 minutes. Is that right?
That's right.
Yeah, so I'll try to, I know we are behind schedule, so I'll try to give some main messages. You know that there are a couple of congresses. There's one here in Barcelona, the ATTD one, so I couldn't attend the 2 previous days, and also the Spanish diabetes meeting in far away from here in the Canary Islands. So it's been a busy time these days. Anyway, Ariel and I were talking about my lecture, and we agreed that I should concentrate on not that much on treatment of the ulcers, but on early detection and prevention. And I will stick to the guidelines because I already knew that we might be behind schedule. So I will start by my. Can you? Yeah, here. Okay. These are my disclosures, and this is the outline of my talk today. And as you know, the primary goals of diabetes treatment, which I always try to put in the head of my younger colleagues, is not any of the surrogates, but is to provide our patients with quality of life, but also with years of life. You know, and this is probably mostly due to complications, and most of the complications, but especially diabetic foot disease has been shown today. They shorten the life expectancy of our patients, and I just use this slide from David Armstrong, and it's not only about ischemic ulcers, it's also about neuropathic ulcers. And you see here the mortality risk at 5 years of our patients, and we have seen some figures from Prash today, which show that these patients are really at a high risk of dying within a relatively short period of time. So these are really complex patients. And what it is all about, the care of the foot of diabetes, I will only talk today about prevention, primary, and something about secondary, but the whole care of the patient, it has been said today as well, involves many clinicians, many expertises, and it's really a complex patient, as you may know. And I have based my talk on the International Working Group on Diabetic Foot Guidelines. You can find them here at the website. You can download them. You have also these guidelines in several languages, including, for example, Spanish. So they are in English and Spanish and some other languages. So please, this is what I would say our Bible in daily clinical practice, at least to guide our decisions on the patients. And when it comes to prevention, the key elements are first identifying the foot at risk, then regularly examining the feet of the patients. Education is one of the pillars of the care of these patients, but not also the patient, but also the education of healthcare professionals. Then it's about also footwear, and finally in addressing the risk factors for ulceration, both in primary and secondary prevention of diabetic foot. And there are several tasks that have been revised today by previous speakers. So how we define the foot at risk is first checking whether there's a history of previous amputations, ulcers, and of course clinical symptoms of both neuropathy and vascular disease. assessing the vascular status, that has been already shown, pulses and whether possible API at least, and then testing for loss of protective sensation, usually by the monofilament or the vibration perception, and there are even alternatives if you don't have these devices to test that. Then if the suspicion is that there's loss of protective sensation, then you should go for further workup on diabetic neuropathy. And I'm not an expert on that, but you are. Most of the speakers have been working on this field. And the IWGDF, they stratify the risk as you see in this slide. Category 0 is not having any of the vascular or loss of sensation, but once you have any of them, you may have a low risk, a moderate risk, and the higher risk is for those patients that have any of these two problems added with the addition of a previous ulcer or leg amputation, and especially end-stage kidney disease, which is a major risk factor. Once you have identified food that is really at risk, whether it's low or moderate or high, then you should check at different times. We will see that afterwards. You should check by history, as we said, vascular status, the state of the skin, look for deformities, prominences, joint mobility, of course, assessing regularly neuropathy, checking footwear and the hygiene of the patient, the self-care practices, and physical limitations for self-care. And you know that some of these, especially retinopathy and visual loss, are putting the patient at very high risk for future ulceration. And of course, what is the knowledge of the patient and their carers? And these are probably the high-risk areas, just to illustrate that. And then one of the main things is education. We should educate our colleagues, especially GPs. I mean, most of the messages I'm giving today stand on the primary care level. Prevention is very important, not to reach the ulcer status. So we have to educate the patient on who is going to check the food. Sometimes the patient is not capable, so we should advise the carers how to perform the food inspection, how to identify the alarm signs, and review the practices of the patient. And most of the time, we should tell the patient on what to do, but especially what not to put on their feet. I'm not going to check, but structured education is fundamental. And of course, appropriate footwear, as we will see. And finally, it's treating risk factors, especially treating those known risk factors, especially pre-ulcerative signs in the food. Sometimes performing surgical intervention to prevent re-ulceration or new ulceration, and then regular exercising. I was amazed by the previous talk. I've learned many things from my colleague, Maria Jesus Jimenez. So I'm going through the 16 recommendations briefly that were issued in the previous guidelines. These guidelines are revised every 4 years. Previous one was 2019. So next year we are waiting for further recommendations for a new version. I must say that they are very well elaborated using standard state-of-the-art great recommendations. So in total, we will go briefly through the 16 recommendations and that they are stratified regarding the main problems that I have already shared with you. First, the identification of at food risk. I won't go through the PICO questions that you have in the upper part of the slide. The first recommendation is on identification of the at-risk food, as I said, and it says that even if the patient has no risk, it should be examined annually for signs or symptoms of either vascular or loss of sensation, protective sensation. That should be done in every patient yearly to see whether the status has changed to an at-risk food. As I said, I won't go through the details of each recommendations, otherwise it would take me a long time. The next set of recommendations concern the next two, concern to regular examination of at-risk food. And the first one, which is recommendation 2, is on patients that are already at risk, either low, moderate, or high, and we should screen them for history of ulceration, lower of previous amputations, chronic kidney disease, foot deformities, limited joint mobility, presence of cones, callus, and any other pre-ulcerative signs on the foot. And then the guidelines recommend on the frequency that you should assess each of the categories. So from risk 0, you just check the patient, any diabetic patient, and then you should intensify the follow-up as you see on the right side of your screen, as it's specified, especially those patients and those who see diabetic foot patients know that the patient always comes back either for control or for a new ulceration, and unfortunately sometimes the patient doesn't come back because we lose the whole patient. Then we have 3 other recommendations on education, and this is very important. We have to instruct the patient on foot care, and the first one is instructing those at risk to protect their feet, and mainly to avoid walking on some conditions as you see here. This is one recommendation regarding foot self-care, and then there's another one. We should instruct, encourage, and remind, and you know that these patients sometimes are non-adherent, to inspect daily the entire surface of the foot, either by the patient or by the carer, to check the insoles, to check the shoes, to perform any hygiene examination and wash and lubricate the skin, and of course avoiding putting on the foot agents that may be a risk for the foot. Then the final recommendation on education is structured education, and this is a weakness in many centers that do not have structured education for diabetic foot self-care. And especially in patients at risk, we should provide structured education. We should have part of the program for diabetic foot care should be the structured education about appropriate self-care, especially in those patients at risk. And you will see that the evidence, it's not always high, because the diabetic foot has been, they called that many years ago the Cinderella of diabetic research. The situation has improved, but we need much more evidence in this area of diabetology. Regarding self-management, you see this recommendation number 6. It says consider, because we don't have a solid evidence, but in many places we don't do that. But in many places they recommend to check the foot temperature in those at moderate or high risk. And the thing here is that we should instruct the patient to detect any situation that put their feet at risk, and to seek help from us. So we should encourage them to consult once any alarm sign is there. What about footwear? We have 3 more recommendations on footwear. The first one is to instruct patients with at-risk food, moderate or high risk, to wear therapeutic footwear that accommodates to the shape of the feet, and checking that it fits properly to the patient feet. Then sometimes we should consider a custom-made footwear. I know that that's not available in all the healthcare system, but we should, whenever possible, use this strategy. Then we should consider in those patients with some deformities, we should use orthotic interventions like toe silicone or orthotic devices to help reducing especially calluses and areas with unnecessary high pressure. Then the last one on footwear is that in a patient that has a heel plantar foot ulcer, we should prescribe adequate footwear to prevent recurrent plantar ulcer. And it's not just prescribing, it's just encouraging its use. You know, these patients, usually many of them are not so adherent. So it's not just prescribing, it's just following them up, reassessing the footwear, because not always it fits in initially in the foot of the patient. And then there's a good number of recommendations in the chapter of treating risk factors. And regarding treating those pre-ulcerative signs, the recommendation number 10 states that we should provide appropriate treatment for those with pre-ulcerative signs or calluses or ingrown, say, toenails, or any other condition like fungal infections that we know are the first step to starting an ulcer in our patient's foot. So regarding the surgical interventions, although there's no much evidence, as you may see here, there are some interventions that are at least in hands of several centers, and we have good experiences with that. When there's an ulcer or a callus in the apex or the distal part of a non-rigid hammer-toe that either has failed to heal or to solve the callus, we should consider digital flexotenotomy for preventing or having a first ulcer or recurring ulcer. Then regarding other interventions in plantar for foot ulcers, we have several interventions that sometimes relieve the pressure in the place of in the site of the ulcer, like Achilles tendon lengthening or arthroplasties. One very useful one is the resection of metatarsophalangeal joint, and then an arthroplasty or an osteotomy. But that should be done by an expert orthopedic surgeon. And this have been shown either to prevent a recurring ulcer or even to solve some of the ulcers that do not heal. Other surgical interventions, here there's an intervention that sometimes is used for neuropathies, nerve decompression, and this is not advised for those patients who with food risk, with moderate or high at food risk. As you see, there's low evidence on that, so we need much more research. And finally, there are, regarding the exercises in this area of treating risk factors, we should consider advising patients with at-risk foot, low or moderate at-risk foot, to perform foot and mobility-related exercises. For that, physiotherapists are the ideal professional that should do that, with the aim of reducing risk factors. Okay. And another set of exercises may be considered in those patients with moderate increase risk, low or moderate risk. So it is advised that they may increase the level of walking-related weight-bearing daily activity that is safe, and we should advise, of course, to wear appropriate shoes during these activities, and especially to monitor the food once we have done the exercise. And finally, there's a message that has been already mentioned by previous speakers. We need many expertises in diabetic food care. So it is advised that at least in those patients with ulcers and risk-free, very high risk, we should provide integrated food care to prevent the recurrent ulcer. So we need all the professional expertises, professional food care, and all the associated treatments. So to conclude, these are the key issues: identification of the food at risk, checking and examining those feet that are at risk. Education is essential not only to the patient and family, but also to healthcare professionals, especially GPs, which in many systems are the first line in prevention strategies. Then footwear, always important, and then, as you have seen, treating risk factors. Of course, the prevention does not consist only in checking the food. It consists also in checking the whole patient. And I didn't mention that, but of course, it is essential that we take care of all the comorbidities and especially diabetes itself in these patients. And finally, there are many gaps in research, and this guideline checked after they made systematic reviews. We need many more trials in many aspects of the diabetic food care, including the state-of-the-art integrated food care, organizational aspects, education, which is the effect and which is the best educational intervention, cost and cost effectiveness. You know more than I that neuropathy should be subject of much more investigation, because there's still scarce evidence on its prevention and treatment. And also for screening, there's not robust data on that. So we need much more research in this area. And with that, I thank you very much. I think I stick to the allocated time. So, Ariel, thank you.